This one is going to be on the role of emotional dysregulation in ADHD and what that means for understanding comorbid disorders, but especially for diagnosis and management of ADHD. So again, more slides than I probably have time to cover, but we'll do the best we can to get through this in the brief hour that we have together. And I will try to leave some room at the end for question and answer as well. So I want to review with you the nature of emotion itself and especially self-regulation of emotion. Then I'm going to go through 7 lines of reasoning, of argument and evidence as to why emotion is as central to ADHD as are the attention problems and the other traditional DSM-based symptoms. And then we're going to summarize some of the research on the impact that emotional dysregulation has in major life activities of these individuals. I also want to talk about some of the findings with regard to diagnosis and treatment. So those are our objectives. We have a lot to go over, so let's get started. The current clinical view of ADHD, as I briefly mentioned it this morning, but let me go into some more detail, is that it's a developmental delay in 2 dimensions of neuropsychological brain functioning development. Now, that statement is rich with meaning because developmental delays are not psychopathologies. A psychopathology is a gross aberration in an individual's behavior, allowing us to recognize the disorder at any age. Bipolar disorder, for instance. We don't have to do age comparisons for mania to tell whether or not you have a disorder. So there are these pathologies like schizophrenia and bipolar disorder where we don't do age-adjusted criteria. If you have it, you have it. But with ADHD, like other developmental disorders, the disorder is defined by the degree of delay in the trait. It's a quantitative difference, not a qualitative difference. And so for language disorders, learning disabilities, mild mental retardation, and ADHD, we have to do age comparisons to see what is the magnitude of the deficit. And it's that magnitude, that quantity, that defines the disorder. And so right at the beginning with ADHD, we know we're dealing with a neurodevelopmental disorder that originates in neurology and genetics of the individual, not in the social environment. Now, there are 2 traits that are not developing on schedule in the person with ADHD. The first, of course, although it's called inattention, as I mentioned to you this morning, is really a metacognitive dimension, an executive dimension that is filled with symptoms of working memory deficits, failure of language to guide behavior, activation, motivation problems of the individual, and so on. So if we look at the attention problems or the executive deficits here, we see the things I mentioned this morning. The first, poor persistence over time toward goals. Clinicians call that sustained attention, but William James called it persistence because it's on the motor side of the brain, not the sensory side of the brain. The word attention implies some kind of processing, filtering, perception, selection. And ADHD doesn't involve those things. Instead, ADHD is a failure to string behavior together over time to get to a goal. That has to do with frontal lobe output motor functions. So persistence is a far more accurate term for this than sustained attention because it clearly conveys the problem on the behavioral side of the brain. You can't string together sufficient complex chains of action the way other people are able to do to get toward that future event, or the task here, if you will. Now, linked to the failure of persistence is a problem with resistance to distraction. This also is a motor problem, not a sensory problem. The person with ADHD reacts to distracting events more than others do. He doesn't perceive them any better than other people do. But what other people do is suppress responses to goal-irrelevant events. They're not part of what you were doing. You simply don't respond to them. So there's an inhibitory part of the distraction here that needs to be appreciated. It's the failure to inhibit responding, not the perception of the distraction that's at issue. So that is coupled with the failure to persist. If you can't persist, you won't resist distractions, and vice versa. They are opposite sides of a common coin. Now, once the individual is disrupted A third difference emerges here. The person with ADHD is less likely to re-engage an incompleted goal. You get distracted all the time, but once you've dealt with the distraction, if it's something urgent or important and you have to stop what you're doing, shift to that, you will come back and finish the goal you started. And they don't do that. Now, goal re-engagement is not an attention disorder. It's a working memory disorder. Working memory, as we said this morning, is the ability to hold in mind information that is guiding behavior over time, remembering so as to do. And therefore, if you have a problem with working memory and a distraction disrupts your working memory, you won't remember what you were doing. You won't get back to the work that you were doing. You're going to be like somebody my age. After 55 years of age, your working memory starts to decline. Actually, in women, even more dramatically than men, particularly around perimenopause. So people with ADHD are like perimenopausal women and old men. They can't remember what they were doing. They go outside, they're supposed to go to the mailbox, they see the newspaper, they pick it up, they read it, the trash can needs to be brought back in, there's a few weeds in the bed, so we pull those, and we wander back inside with the newspaper. And your wife says, "Did you get the mail?" Which is what you went out to do to begin with. So that's a working memory disorder, because what happens is as working memory decays, the strength of the environmental events takes over. Because mental events aren't guiding you as powerfully as external events. You become more field dependent as you age. Well, ADHD individuals have that problem at the start. They have this problem with a very weak working memory system that doesn't guide behavior, is easily distorted and wiped out by any outside distracting event. And then they're skipping from one uncompleted activity to another. So when you hear that symptom or that complaint about these individuals, that's a working memory symptom, not an attention symptom. Now, in addition to that, we know that there is the hyperactive impulsive dimension. But here, too, I want to emphasize that it's cross-modal. The DSM represents ADHD as verbal impulsiveness. It has 3 items that measure disinhibition, and they're all verbal. Talks too much, interrupts others, blurts out. But the problem with inhibition in ADHD is vastly more complex than that. We tried to get 5 new items into the DSM-5 to capture this range, but the higher level committees in DSM-5 rejected any changes that might broaden the prevalence of the disorder. And so as a result, there were a number of science-based changes to DSM-5 that never got in, because there was this growing fear of prevalence alteration. And that became almost obsessional by the committee to the point where they decided not to make too many changes. The point here is this: we have a problem with not just verbal impulsiveness, with motor impulsiveness, with cognitive impulsiveness, rapid decision making, failure to think about the future. And of course, if you have that sort of rapid impulsive decision making, you are going to have what economists would call a very high time preference, which means you prefer things now. And the more you have to wait for something, the less important it becomes, the less valuable it becomes. And we all show that kind of what's called reward discounting, which is where you discount a consequence because of how long the delay is. But ADHD people show a steeper discounting than the general population does. That's evidence also of problems with impulsiveness, with a failure to stop and think before you act. Then, of course, you have the excessive off-task, irrelevant activity, the restlessness, the hyperactivity, and so on. But as I said this morning, that declines with age, and by adulthood is not symptomatic of this disorder. Okay, so that's the current DSM-4 or DSM-5 based view, and that's also the way science would look at ADHD currently as well. What I want to show you, however, is where emotion fits into that and why you have to put it back there. Now, very quickly, what is an emotion? It is a short duration change in your arousal, your alertness, and your motivation. So emotions can be plotted along these dimensions, and they all contain this sort of behavioral dimension, motivational dimension. There's an approach avoidance to this. There's a reward punishment aspect to emotion, and there's physiological arousal. So we're not going to spend any time on that, but that's how we think of emotions in psychology. What people need to keep in mind is that emotions have a variety of purposes. They're not just cathartic, they're not just for reducing arousal, they're communicative. Emotions were one of the first forms of animal communication in nonverbal organisms, and they remain forms of communication, very primitive ones, but they convey to others around you a change in your motivation, a change in your action, in your stance to the environment, if you will. So it's not just for catharsis. Okay, that's what an emotion happens to be. Now, what is emotional self-control? Because humans have this second aspect of emotion that other species lack. And emotional self-control is the capacity to voluntarily inhibit the expression of the emotion. You feel it, you get the autonomic nervous system part of it, changes in heart rate, respiration, your flushing of your skin, maybe tearfulness. These are things you can't very easily regulate, but you suppress the voluntary, the motor aspect of the emotional display. So step one in self-control is suppressing the primary emotion that's been provoked by what has happened around you. Step two, which starts very early in infancy and progresses in childhood, is you begin to direct activities at yourself to calm down. Little babies who are upset reach for people, reach for the silk liner on their blanket, stroke themselves, curl up into a ball, and begin to engage in self-calming, self-soothing activities. So humans try to use self-directed actions to calm down. Then as we get older, we do this. We learn to refocus attention away from the stimulus that's provoking the emotion. Because by breaking contact with the stimulus, we give our emotional system a chance to calm down. By staying engaged with an emotional stimulus, you're just further activating your limbic system. So there's a refocusing of attention away from the stimulus, including putting your hand over your eyes, turning away, leaving the situation. All our ways are of interrupting contact with the event. Then we get to the more complex activity that doesn't come until later in childhood. We begin to create another emotion in place of the detrimental one. We literally can create a new emotional state to help us calm down and even replace the primary emotion that is not in our best interest. Very simply, it's what parents teach kids to do. Count to 10, go to your happy place. Count to 10, close your eyes, visualize something positive, like the beach or eating ice cream or something that's really fun, and that visual imagery will bring an emotion with it that will help to lessen the level of the primary emotion that you're feeling, in this case, frustration or anger. But only humans have a capacity to generate a new emotion. In all other species, emotions are provoked by external events, but humans can self-provoke an emotion. This is what actors do. The method school of acting teaches this explicitly. When you see Anthony Hopkins, Meryl Streep, Jeremy Irons, and these people, when you see them act, this is the technique they're using. If Meryl Streep needs to grieve in, what was it, Osage County, this recent movie, or Michael Cunningham's The Hours or something, what does Meryl do? There's nothing on the stage, on the set of a movie, to grieve. So how do you get a genuine grief reaction? Well, you know what she does. She calls up a visual image of a legitimate situation in which she grieved, and to that will be bonded an emotion. So all past events have emotion welded to them of varying degrees. So she chooses an image that has a strong emotion associated with it, and guess what happens? She starts to get flushing of the cheeks, she gets tears in her eyes, and she has a legitimate grief reaction. So that's what I mean by self-control. You can provoke emotions anytime you need them to support the goals you're pursuing in the absence of any environmental provocation for the emotion. It's a very sophisticated level of emotional self-control. So those are the 4 steps for self-control of an emotion. Now, let's take a look at what ADHD does here to screw this up. Now, to appreciate what ADHD is going to do, let's just draw a diagram of what I just taught you, okay? Here we have time, here we have the strength of the emotion, and we have positive emotions and negative emotions. Let's take a negative emotion. Something happens. Maybe another child comes over and he takes your toy from you, all right? And as a young child, this provokes a primary emotion. Frustration, anger, hostility. Right? So, do you express that emotion? Well, if you're really young, 3, 4, 5 years of age, yes. But eventually what humans acquire is that second stage. They begin to enact various actions to themselves to down-regulate that emotion, to terminate it more quickly, so that it's not as strong, it's not as powerful. Eventually, they can even suppress the expression of the emotion. And if needed, if this were a positive emotion, or in the case of Meryl Streep, who needs to grieve, you can continue the emotional state, if you need to, by re-provoking it. And that's what the yellow represents here. So humans have this capacity to create alternative emotions that contradict, modify, and help us manage our emotional state, among others. So, now, of all the emotions we need to control, the negative ones are the most important. And that's because we live in groups. We are a group living species that relies on each other and our social networks to survive. And the negative emotions are very disruptive of reciprocity, cooperation, friendships, and so on. So it's not going to be humor that gets you in trouble with other people, or affection. It's going to be hostility, anger, and aggression. So it's the regulation of the negative emotions that becomes so important more than the positive emotions. You can be a class clown, but if you're a class bully, if you are known to be reactively aggressive, that's going to come with a social price to it, much more than the person who is being silly in school. So if we look at ADHD, and we want to predict that ADHD is going to interfere with emotion, we can automatically see it's going to interfere with both kinds. You're not going to be able to suppress the primary emotions like other people. You're going to be immature. You're going to show emotion more than other people do. And secondarily, you're not going to be able to down-regulate it if you have to. You will struggle mightily to get control over yourself, and it won't be very effective. So you're going to have trouble not only suppressing the emotion, but then down-regulating it and engaging in the 4 steps we talked about: self-soothing and generating alternative emotions and distraction, looking away, interrupting the stimulus, and so on. So if what I say is true, this is what we would see in people with ADHD. And the next question is, do we? All right. Well, you almost have to, for these 7 reasons. And we're going to go through each of these. The history of ADHD, the neuroanatomy, the neuropsychology of the disorder, but especially the evidence base, the psychological evidence that's out there, the longitudinal studies, and then we're going to look at how it explains other disorders that we see with ADHD, but also what it means for impairment. Because I'm going to demonstrate to you that emotions carry with them certain adverse consequences that cannot be explained by traditional ADHD symptoms: the inattention, the hyperactivity, the impulsiveness. And that becomes very important. I think you'd be surprised at what we're able to predict from these emotional difficulties. Finally, we're going to end up with what does it mean for diagnosis and management. Now, one reason emotion needs to be put back in ADHD is it's always been there. For the first 170 years or more of ADHD's existence in the literature, it was there. Everybody who wrote about ADHD, back to Weichert, which you heard me talk about this morning, to Alexander Crichton, all the way up through George Still's lectures, even the early writers describing the condition we call ADHD today, had included passion, emotion, the inability to regulate your feelings, this quickness to anger, and easily frustrated were part of their definition of the condition. So it started out there. And then when we got into the 1960s, as Pat Quinn mentioned about MBD, it was there. It was one of the 5 major components of the disorder. If we look at Mark Stewart's papers, like his Scientific American article describing ADHD children, it's rife with descriptions of aggression, temper, anger, hostility, easily aroused, easily annoyed, quick to emote or arouse. Dennis Cantwell said it was one of the 5 major features of the syndrome of hyperactive children. And Paul Wender not only described it in children, but was the first to describe adult MBD. And he made it a central part of MBD, for which he was roundly criticized at the time. Because people said, well, how can you distinguish that from bipolar disorder or from mood disorder and so on? And you can, but you just had to make a more sophisticated argument for it. So what happened? I mean, all the way up through my early career, emotion was always part of this condition we were now calling ADHD. What happened was DSM-2. DSM-2 came out describing ADHD then as hyperkinetic reaction of childhood. And if you go to DSM-2, which I have on my bookshelf, and you read it, it's only a paragraph, it describes ADHD as involving inattention, distractibility, hyperactivity, impulsivity. But once the official stamp of the APA was put on those criteria, emotion was abandoned and has never returned in any of the subsequent DSMs. Oh, it's occasionally mentioned in the text as possibly an ancillary related comorbidity for some people. But it's not part of the criteria, it's not part of the description of the central features of the disorder. So we have this official, if you will, abandonment of emotion after 170 to nearly 200 years of emotion being part of the disorder. I don't know why this happened. At the time, Stella Chess, a very influential child psychiatrist, was also part of this committee. She was writing papers simply saying that hyperactivity was just that, excessive motor restlessness, nothing more. So we don't quite know what happened back then. It may be that it was the fact that emotions are hard to measure. And this was the beginning of scientific child psychiatry, going out and beginning to measure things rather than just taking Freud's word for it about psychodynamics. Let's go out and actually learn something about our disorders through assessment, measurement, group studies, randomization, and so on. And emotions are much more difficult to assess than is hyperactivity. I don't know why they got rid of it. All I know is it's always been there up until the DSM abandoned it. But according to the neuroanatomy of ADHD, which is our second line of evidence, it has to be there. And we talked about this morning, so I won't spend as much time on this. But we know that there are 5 brain regions that are smaller in people with ADHD. They're at least 3 to 10% smaller, and according to the newest studies, which are looking at microstructure of white matter, it's even worse than that. But at a minimum, we're looking at much smaller regions that are much less mature in their development by about 2 to 3 years. And these regions are the orbital frontal cortex, the midline anterior cingulate, the basal ganglia, and the cerebellum. Now, because the frontal lobes are smaller, especially on the right, then the bundle of fibers that connects the two hemispheres would be smaller, and that's the corpus callosum. So the anterior part of the corpus callosum is also smaller in these individuals, but that's a byproduct. And by the way, ADHD, although it involves an immaturity in both frontal lobes, is twice as bad in the right as it is in the left. And we even see that in our studies of working memory. Nonverbal working memory is twice as impaired in this disorder as is verbal working memory. They're both impaired, but the nonverbal is substantially worse, fitting in with a right hemisphere view that ADHD is much more lateralized into the right than it is in the left hemisphere, but it affects both hemispheres. It's not exclusively right hemisphere. So the point is this. Here are the 5 structures. And as we mentioned earlier this morning, we can organize those 5 structures that you see here. Dorsolateral cortex, here's your anterior cingulate, you've got your basal ganglia right in here, it's hard to see it, here's your cerebellum back here. Right? We can organize these structures, as we said, into 4 networks. Network number 1, as I told you this morning, is from the frontal lobe back to the posterior part of the right hemisphere, and from there, there's also a connection, a network, into the anterior cingulate, which is right here. And this is the network for self-monitoring, for turning your attention network on yourself. And it's the beginnings of self-awareness. You begin to track and monitor your internal and external states yourself. Now you know why people with ADHD have more limited self-awareness, why they don't report their symptoms as being as problematic as other people do. And the younger they are, the worse that difference is, which is why DSM-5 requires that you must corroborate what patients tell you through other sources. You can't take their word for it, because their reports are terrible. There is no correlation between what a teenager says about their ADHD and what their parents say, or what their teachers say. In fact, the two don't even begin to agree with each other until you're in your 30s. So let that be a lesson to you. You never take the reports at face validity of a young person with ADHD because they massively underreport the true state of their disorder. And a main reason for underreporting is more limited self-monitoring, self-awareness. They also show what is called a positive illusory bias. That simply means that they don't see themselves as being as impaired in certain areas as they really are. If you ask somebody with ADHD, how do you think you drive? Pretty good. Not as good as everybody else, probably a little better. Okay? The problem isn't in that report. We all say that. We all have the Lake Woebegone better than average view of ourselves. The problem is, if you look at their driving history, it's awful. They're the worst drivers on the highway. So it's the disparity between the self-report and the evidence that's the problem. They're not manic. They don't claim that they're NASCAR drivers. They don't think they can swim the English Channel having never had a swim lesson. That's bipolar disorder that does that. What they're saying is what normal people would say. But the problem is they're much worse than normal people. What they fail to appreciate is the degree of the deficit that they have in their functioning. All right, so we know from the neuroanatomy that there has to be a problem with emotion because the anterior cingulate and the frontal lobe are involved in ADHD. And we know that they are instrumental to the emotion regulation circuitry of the brain. So it has to be there. And as I pointed out this morning, besides the network for self-awareness, we have these three other networks in the brain. From the frontal lobe to the basal ganglia, again, the what network. What I think influences what I do. Second network, frontal lobe to the cerebellum, the when network, the timing network. And then finally, the one that's important for this lecture is from the frontal lobe through the midline cingulate into the amygdala and the limbic system. And that's the emotional circuit, often called the hot executive circuit. I call it the why circuit because, as I said earlier, it also is helping you make decisions about what you're about to do. If you have a range of options, this is the circuit that makes the final call, which is why you often see neuroimaging studies talking about the anterior cingulate being involved in conflict and conflict resolution. When there are disagreements in your mind about what to do, what not to do, this, I could do that, it will be this circuit that is evaluating their consequences, their emotions, their motivation, how you feel about these options, and then makes the final call. So, as I pointed out to you earlier, you can see all of those networks already mapped on to this brain. So we're not going to spend any time on that, other than to say there has to be an emotional problem in ADHD because the very regions of the brain that give you emotional self-control are not developing on schedule. We also know that various theories of ADHD, including my own executive theory that you heard about this morning, include emotion and poor self-regulation as one of the dimensions that ADHD interferes with of the various executive functioning dimensions. So it's not just me. Other theories say the same thing. You already saw the other papers by Joel Nigg and Beth Casey and Javier Castellanos and others that I referenced on that last slide. So even neuropsychological evidence is saying there has to be a problem with emotion there. So now we cut to the chase. All of this so far is speculative. Is there evidence that emotion is linked to this disorder? Well, if you look at every single research paper that uses a rating scale that has any measure of emotion on it, routinely the emotional scales are very elevated on these scales. So according to people's opinions about children and adults with ADHD, there's a substantial problem with regulating emotion, particularly with frustration, impatience, anger, hostility, and just general excitability and arousal. Direct observation studies. I can go out into a classroom, I can go to this university, I can bring people into the lab and videotape them, and I can provoke emotions and watch them. Their emotions are more extreme, and they can't down-regulate them. So the evidence is there from the observational studies that there is emotional dysregulation connected to the disorder. And within the past few years, studies that looked at the brain itself and at the psychophysiological responses of the brain have found that even at the level of the autonomic nervous system, particularly the parasympathetic nervous system, There are abnormalities in the reaction of the individual to emotional events. And those reactions convey a failure to regulate the emotional event. Now, besides that, we have evidence from family studies, my own, Steve Ferrone, Joe Biederman, and others, that the emotional dimension links up with ADHD in families and is transmitted across family members. So if your relatives had trouble with ADHD and emotional dysregulation, so will their offspring have difficulties with it. So the traits go together, correlate with each other, segregate with each other across family lines. Also, studies of children followed to adulthood, as well as adults with ADHD, clearly show that emotions are problematic. For instance, this is my Milwaukee follow-up study. And again, I mentioned it this morning when I was talking about children and their executive deficits, but let me remind you, we have a group of children who had ADHD in childhood 27 years ago. And I have followed these children ever since. And as part of their assessment when they were young adults, we asked them about a range of emotional symptoms. Now, to keep the graph from getting too busy, I only put 5 up here. But I could have put the other 5 and you would have seen the same result, so it doesn't matter. The point is this, look at the red bar. Those are the kids whose ADHD remained fully diagnosable at 27 years of age. We're going to call it persistent ADHD. By the way, it was at a minimum 2/3. 65% of people with ADHD will be fully ADHD in their 30s. We did find that about 14% had fully recovered, and the remainder were what we call subclinical. And those two groups are put together in the what we call non-persistent category. And then you see my community control group that we followed over the same period of time. What do we see here? First of all, we see that if your ADHD persisted, so did your emotional symptoms. And in fact, your emotional symptoms are occurring as frequently, see the percentages, as the DSM symptoms, the one we use for diagnosis. So it's not like these are lesser symptoms. They're just as common, just as prevalent, just as severe as are the ADHD inattention and hyperactive impulsive symptoms. But we also see in the blue bar that if you're starting to recover from your ADHD, you're starting to recover from your emotional dysregulation. But you're still not normal. That's the yellow bar. You still have some problems, but not to the degree that the diagnosed persistent group does. Now, here's the same interview and rating scale, assessing the same symptoms, but with a group of adults with ADHD. And look at what you see here. The adults are massively more emotional than the control groups that we use in these clinical studies. And again, if you look at the frequency with which these are occurring, their prevalence, they are as prevalent as the DSM-4 symptoms. So if you have ADHD, you are going to have emotional dysregulation to the same extent you have ADHD. They're directly in line with each other, as common, as problematic as your attention and inhibition and hyperactive problems, but especially inattention and inhibition. So when we go back over the evidence, the history says it's there, the neuroanatomy says it's there, and the neuropsychology says it's there, the evidence says it's there. So what does it mean? Well, first of all, if you put emotion back into ADHD, you can start to explain the comorbid disorders that link up with it. Right now, people treat comorbidity if it's just stuff happens. Okay, ADHD kids are 11 times more likely to have oppositional disorder. So are adults. By the way, ODD is an adult diagnosis, not just a childhood diagnosis. And it's as highly persistent as is ADHD. Why would ADHD link up with oppositional disorder, and then with conduct disorder, and then with anxiety, and then with depression? By putting emotional dysregulation into ADHD, you can see those pathways much more clearly. Let me explain them to you. ODD is a pattern of hostile, defiant, aggressive behavior, willfulness to refuse to obey another individual, resistance to authority. As we've said, it is the #1 comorbidity in ADHD. 65 to 84% of ADHD children will have ODD. It's also the most common comorbidity in adults, but clinicians tend not to diagnose it. They think ODD is a kid's disorder rather than an adult's disorder. We need to keep in mind that ODD forms 2 dimensions. Even DSM-5 is finally acknowledging that ODD is not a single dimension of symptoms. And the 2 dimensions are 4 of the symptoms are emotional, the anger, the hostility, the temper, and 4 of them are social conflict. They take another person to have that symptom. You're refusing, you're defying, you're resisting authority. Now, the reason that we split ODD into 2 dimensions, and why DSM-5 had to do so, is because the 2 dimensions arise from different sources and make different predictions over life, over time. So, the emotional symptoms of ODD come from ADHD or a mood disorder, like bipolar disorder. So there's a biological basis to the emotional component. It's an inherent feature of the person, not of their environment. Something has predisposed this individual to being very emotional. In this case, it's ADHD. It's that executive function we just talked about. You can't self-regulate your normal emotions. The second dimension of ODD is the social conflict dimension. Where does that come from? Learning. Unlike ADHD, half of the variance of oppositional disorder is learned within a family environment. The training is inadvertent. Parents don't mean to be doing it, but they're doing it anyway. So half of ODD's severity has to do with who is raising you and how good or how poorly their parenting is. So disrupted parenting is the source of the second dimension. ADHD is the source of the first dimension. And you put both of those together, you are going to get clinical ODD. To put it another way, if you're diagnosed with ADHD, you are halfway down the road to ODD. All it's going to take is for you to be raised in a particular environment with a parent who can't manage you very well, and you are off to the races, honey. So it takes both. The environment interacting with these genetic predispositions toward emotional dysregulation to get that. So we need to understand then that there are 2 dimensions to ODD arising from different causes and making different predictions over time. If you follow these children over 10 years, the emotional dimension predicts the development of depression and anxiety by adolescence, but especially depression. The social conflict dimension of ODD predicts conduct disorder, antisocial behavior, crime, psychopathy, drug use. So these 2 dimensions are not coming from the same sources, nor are they predicting the same risks or outcomes over time. You have to understand both dimensions to know the risks that are carried forward here. And now you know why 25 to 35% of ADHD children get conduct disorder, 25% of them go on to have depression, 25 to 35% get anxiety disorder, and the risk of anxiety disorder increases with age. By adulthood, 45% of adults coming into clinics with ADHD have developed an anxiety disorder with their ADHD. And a lot of that has to do with that emotion dysregulation dimension. They can't cope with emotions as well as other people are able to do. Now, as we've said, ADHD does contribute to ODD, and it is likely through that emotional dimension that it is doing it. But we also know that ADHD predicts ODD through disrupted parenting. And I'm going to explain that little pathway to you in just a moment. But by understanding the role that ADHD plays in generating oppositional disorder, we now can go back 40 years and explain one of the most common findings in drug studies. If you give an ADHD medication to somebody, you improve their ODD as much as their ADHD. Even though they're ADHD drugs, they treat oppositional disorder as much, as effectively as they treat ADHD. The 2 dimensions are correlated 0.8 with each other. Now, why would these drugs treat ODD? Because part of ODD is ADHD. And if you can get control of the ADHD emotion, you can get control of what's contributing to ODD. But only if you intervene early enough. If this child remains dysregulated long enough within a family of disrupted parenting, there's a learning component that's going to take place. And guess what? If you intervene later at 8, 9, or 10 with your medication, you are not going to get rid of that ODD. You'll only get rid of the part that was linked to the early ADHD. You won't get rid of the part that was due to training. No medication is going to reverse your learning history. So, to put it another way, the longer you let ODD go untreated, the more likely that social component is going to get in there, and then your medication isn't going to resolve the ADHD This is why we argue for very early intervention with ADHD children. Even the American Academy of Pediatrics revised their guidelines a year ago, telling pediatricians to start at 4 or younger. Get in there, because we're trying to prevent not just impairment, but comorbidity. Because once it gets going, later treatment isn't going to rectify the problem completely as much as it would. Simply put, you could prevent ODD if you intervened early and often enough, but we don't. Average age of medication is 8. That's 4 years this kid has gone from original symptom onset to when he finally gets treated for that learning history to take place. Now, as I've said, the social component of ODD is learned. It's learned from this pattern of parenting. Indiscriminate use of consequences, high rates of expressed emotion, yelling, screaming at each other, making threats, and vacillating between lax discipline, you do nothing even though your child is obnoxious, to harsh discipline. You practically beat the kid to a pulp if he misbehaves. But you're all over the map in your parenting. You are as emotional as your child is in your parenting. Where does disrupted parenting come from? Why are these parents doing this? Well, we found out the answer in the last 10 years. The parent has ADHD too. It's a genetic disorder, hello, right? If the child has it, 35% of the parents carry the same disorder without treatment. And adult ADHD, as we now know, disrupts your parenting dramatically because you're impulsive, you're emotional, you're inconsistent, you don't persist, you can't follow good rules of parenting. You are as emotional as your child. So now I got 2 ADHD people trying to get along with each other, living in the same household. And that sets the training in motion. So notice, the child's ADHD contributes to ODD through the emotion dysregulation. The parent's ADHD contributes to ODD by disrupting their parenting and allowing the child to learn how to use emotions to coerce people out of certain interactions with them. Keep in mind, ODD and defiant behavior is not to get attention. It's negatively reinforced behavior. It is designed to get you to back off. I don't want to do that. I don't want to do homework. I don't want to go to bed. I want to play video games. That is not attention getting. And if I can elevate my anger faster than you, there's a good chance I can get you to back down. And that's what you see here. Is parent and child reinforcing each other's behavior on a partial schedule of success and failure for using anger as a social tool to get along with each other. But we know the reason the parent is doing it, and that's because the parent has a psychological disorder as well, and the most common is adult ADHD, although there are other disorders, depression, drug abuse, and so on, that will do that too. In fact, depression is even worse than adult ADHD at disrupted parenting. Okay, for you people who only have a right hemisphere, let's diagram what I just said. Make it easier for you to understand. This is our oppositional child with ADHD. We're going to split his oppositionality into its 2 components. All right? Now, where are those components coming from? This is called the 4-factor model of oppositional disorder. It is the most tested and proven pathway for oppositional disorder. Factor number 1. The child brings to the equation an inherent dysregulation of emotion. Normally, that's ADHD that's doing that. But it could also be bipolar disorder, severe mood dysregulation disorder, depression. All of them bring with it an inherent propensity for emotion. But ADHD is number 1 in that hit parade. That contributes to the emotional part of the child. That's a given. That comes with the equation, with the turf. We also know the hyperactivity contributes a little bit to the social component. Now we get to factor number 2. As we've said, the parent and the parenting behavior, highly disrupted. That is training the social component. You put these 2 together, you're going to have a defiant child on your hands, and very quickly. By the way, in case you doubt this, studies actually have taken normal children and parents and trained the parents to act this way, and literally within 30 minutes, they can turn a normal child into an oppositional child. So we already know from experimental manipulations that this theory is in fact correct. It isn't just hypothetical. Then we get to factor 3. What is driving the inconsistent parenting? The parent has a psychiatric or psychological disorder. And the most common of those is adult ADHD. The second most common is major depression. And these lesser disorders will do it as well, but those are the big two. And they will massively disrupt your parenting, and that is going to lead to training of your child in becoming oppositional. And then there's factor 4, which if I gave you time to think about it, you would have come up with on your own. There are background ecological factors that affect both the parent and their parenting. How about marital discord? How about marital violence? How about being married to a partner who also has a psychiatric disorder, like antisocial personality or drug use disorders? What about raising your child in an impoverished environment that is criminogenic? Adults outside the home are likely to be training this child in doing these things, not just people inside the home. So we have a whole social ecology that is making indirect contributions here. So understand this, defiance starts here. These are the two direct pathways. 1 and 2 are the causes. But we have to step back from there and say, what's causing them? And we move back to the indirect causes, which are these two. But let me tell you, once this cycle gets going, it feeds back to make it worse. The worse this kid gets in his oppositionality, the worse that parent gets in their depression, their irritability. And so we have a nice little cycle going here between these two people. And by the way, it also feeds back into the social ecology as well. You have a hurricane here. This is a tornado of reciprocal influences that are cycling back and forth, making each other worse over time. No wonder by the time this kid is 12 years of age, if he has ODD, the odds of him being delinquent conduct disorder are very high, and the odds of you doing anything about it are less than 25%. That is your success rate with an ADHD oppositional conduct disordered youth. The game is over. If you think once-a-week family therapy is going to handle that family, that is a joke. In our study, they were successful only 5% of the time. So the lesson about ODD is either you get in early and you treat this, or you are not going to get a handle on this. The longer the learning environment gets to train the individual, the less likely you are to intervene successfully with that individual. So that's your 4-factor model. Now we can understand comorbidity. Why do people with ADHD get ODD, get conduct disorder, get anxiety, get depression? That's the model that helps us to understand those pathways and those risks. All right, we've seen 5 lines of evidence now to argue for emotion being put back into ADHD. Let me give you another one. Right? The emotional symptoms predict risks that are not accounted for by the other symptom dimensions. So my colleagues and I, using all of our databases, went into them and said, okay, let's prove to people that emotion matters. We're going to control for the severity of all your ADHD symptoms, and then look and see, does emotion still predict anything? If I'm wrong, emotion adds nothing to the prediction. It's already explained by ADHD. If I'm right, emotion makes its own predictions, even controlling for inattention, hyperactivity, impulsivity. Well, the number one predictor that emotion predicts, despite the severity of all your other symptoms, is social rejection. It is the number one predictor of how many friends you are not going to have. Other people can tolerate your distractibility, your inattentiveness, your laughter, your fizziness, and so on. What they cannot tolerate is your anger, your impatience, your frustration. People will pull back from you in 15 to 20 minutes. Chuck Cunningham did a great study, and Steve Hinshaw replicated it. It does not take hours or weeks for other children to reject you. It takes minutes. You drop an ADHD child into a brand new peer group, and those other kids are pulling away from that kid in 20 minutes. And your reputation is sealed. They want nothing to do with you. They can't manage you. They can't interact with you. You're a little hothead. You're this firecracker going off throughout the day. Nobody wants to live with that. And so they avoid you, and they pull away from you. So you want to know why these kids have no friends? It's not their inattention. It's their frustration and anger and emotion. We also, when we followed these children up into adulthood, or when we looked at our clinic-referred adults, found that it was the best predictor of marital dissatisfaction and inter-partner hostility. It's also a predictor of dating violence in adolescents and college students. You want to know who is at high risk for having partner violence in an intimate relationship, it's the ADHD young adult. And this was now replicated in a study of 50,000 people in England were evaluated looking at predictors of crime and violence and accidental injuries and so on. And even they came up with this link. Adult ADHD is directly related to intimate partner violence. Not violence against strangers, not the sort of psychopathic crime of mugging or robbing stores, but intimate partner hostility and violence was predicted by ADHD. So our research isn't the only one that is seeing this pathway of ADHD into difficulties in intimate relationships. We also found that the emotional symptoms of a child were the best predictor of how stressed that parent's going to be. It's not the child's hyperactivity, it's not their distractibility, it's that child's anger. That is what drives the parents to make the referral. It is what drives their ratings of how stressful they are in trying to raise this child. This may surprise you. We've done detailed studies of driving in adults with ADHD and in my longitudinal study of ADHD. We have their driving records. We have behind-the-road evaluations. I have a $100,000 driving simulator that we use to assess your driving. We looked at driving from all aspects. And then we ran it through the analyses I mentioned, and what did we find? Emotion predicted these outcomes of driving. It makes sense that it would predict road rage. Did you know that adults with ADHD are the most common people to have road rage on the highway? Well, that's where it's coming from. It's not just their risk-taking and their love of speed and desire to, pass you on the highway or something. It also explains their anger, their hostility when they're frustrated while they're driving, not to mention their use of alcohol and their crash risk. We looked at the adults. How are you functioning at work? What does your employer think of you? How many times have you changed jobs? How many times were you fired in the history of your work? Emotion was the best predictor of the number of times you've been fired from a job. Here again, ADHD symptoms predict how well you do your job. Emotional symptoms predict if you're going to get fired, because employers will not tolerate that in the workplace, especially toward customers, not to mention other people in the workplace. Again, we found it was a predictor of dating difficulties, especially hostility and violence. We have the credit reports and complete surveys of the finances of our children that we followed to adulthood. So we went back and looked at financial management, how you manage money, and these were related to your affect dysregulation. Overuse of a credit card, exceeding your credit limit, impulse buying, and so on. And then we went back and looked at your parents. How emotional were your parents? There was a direct correlation between the degree of impulsive emotion in the parents and in the children. And as Steve Ferrone showed, this is highly heritable. This isn't just through learning. This is because both of these people have ADHD as well. So all of this is to show you that there is value added in including emotion in our conceptualization of ADHD besides its two traditional symptom dimensions. We learn things about our patients we would not have realized by understanding the emotional element of the disorder. Now, what does this mean for diagnosis of ADHD? First, it means don't mistake the emotions of ADHD for another disorder. You don't have to go searching for some other mood disorder or the new DMDD, disruptive mood dysregulation disorder now is the new one that's in there, major depression and so on. Emotion is part of ADHD. So there's no reason to add a comorbidity. On the other hand, some ADHD children do develop bipolar disorder, major depression, anxiety. What's the difference? What evidence can I give you? The environment's one, for sure. Let me explain to you several differential diagnostic tips to help you sort out what's ADHD and what's a mood disorder. Number one, the problems in ADHD are emotions, and emotions are short duration. All right, so this is a short duration event. In contrast, moods are long duration events, lasting hours, days, weeks, right? Doesn't the DSM require that the mood be there 2 weeks or longer as the predominant mood, more often than not? Of course it does. So an emotion is short duration, a mood is long duration. Number two, the emotion is provoked. Something in the environment triggered this response. In a mood disorder, it isn't. You can have people fluctuating through these mood states of mania and psychotic depression as if they're bipolar, and it has nothing to do with the provocation around them. So, one is provoked, one isn't. Number 3, the emotional reaction of the ADHD person is rational. You'd have had the same reaction yourself. What's the difference? You suppressed it. You felt it, but you didn't show it. So the emotions we see in people with ADHD are perfectly reasonable. We understand, we identify with them. What we don't identify is why the hell didn't you inhibit this? You are so emotionally immature, you just let this stuff fly. The rest of us learn to suppress, calm, regulate, distract, downregulate. You can't do that. So they're rational. The emotions of the person with a mood disorder are irrational. You don't know why they're feeling the way they do. And it may be an irrational event that's even led to this manic episode that you're having. So to reiterate, the problem in ADHD is a short duration emotion that is often provoked, situation specific, reasonable, rational, but immature. You're not inhibiting. It's a top-down executive failure in the management of normal emotion. To put it briefly, there is nothing wrong with the limbic system in people with ADHD. There is in people with bipolar disorder and depression and anxiety, but not in ADHD. The problem is in the executive that's trying to regulate the limbic system. The top-down control is absent or delayed, immature. Whereas in mood disorders, they're irrational, they're long duration, they're cross-situational, they're capricious, and they vacillate. So that's the kind of thing you're looking for to tell whether or not the ADHD explains the whole clinical picture, including the emotion, or whether I need to go searching for a second disorder to explain those moods. So, don't mistake a mood disorder for the emotions of ADHD. As we've said, they're long duration, cross-situational, and so on. And you're going to have to deal with that comorbid mood disorder separate from ADHD, because the ADHD treatments will not treat the mood disorder. By the way, you can treat the ADHD in a bipolar patient or in a depressed patient, but at least with bipolar patients, we ask that you treat the bipolar disorder first. You always treat the more severe condition before you double back to treat the other one. But you can use ADHD medications with people who have bipolar and comorbid ADHD just fine. Right? So whereas people used to say, oh, we can't give them stimulants because that will provoke manic episodes in these individuals, and that is not true. We have no evidence that stimulants provoke manic episodes in these individuals. So that's what it means for diagnosis. Know which affect goes with ADHD and which cannot be explained by ADHD. Now, what about treatment? Well, number one, we understand that the emotional symptoms of ADHD, that's what this acronym stands for, will be improved by ADHD medications as much as their ADHD symptoms will be. That's the point I made earlier. The ADHD drugs are controlling the emotional dysregulation that is part of the ADHD. But they won't control the symptoms of oppositional disorder that are part of the social environment that was learned. So let me put it this way. If you medicate a child with ADHD at 8, 9, or 10, and after medication the ADHD symptoms are under control, and you still hear complaints about oppositional behavior, that's learned. You are going to have to come in with a behavioral parent training program or some other intervention that works on rational, reasonable parenting, consistent parenting. On the other hand, the younger the child that you medicate, you may be likely to hear that the ODD resolved right along with the ADHD, because most of it was driven by the ADHD, and the learning component didn't have a chance to take hold. So the older the child, the more you're going to be doing behavioral parent training in order to deal with that disrupted parenting. Now, I also want you to understand that the ADHD drugs don't regulate the emotion of ADHD identically. They all do it effectively, but they do it through different pathways. And this can help you to understand the drug responses that your patients, your clients may be having. For instance, let's take the stimulants. The stimulants work in controlling emotion by suppressing the limbic system. The higher the dose you give, the less activity in that system. Okay, well that's certainly one way to skin a cat, isn't it? I can control your affect by eliminating your affect. But remember, the limbic system was not impaired in ADHD. It's not part of the ADHD neuroanatomy. But one way to control emotion is to prevent it from occurring to begin with, and that's what the stimulants do. And now you know why 1 in 5 patients complains to you of emotional blunting, that the patient becomes like almost an automaton. They begin to lose their affect. Yes, they're compliant. Yes, they're productive. Yes, they're obedient. But that's all they are. Parents in particular are very concerned about this side effect and often stop their stimulant medication because they don't like what this child has become. They don't see the joie de vivre, the affection of the child. We want this kid to be poking his sister once in a while, to be getting a little upset. I don't need a bland robot that sits at a computer. And yet some of these kids can get that way. So we have to be careful with stimulants because if you push the dose too high, you can get blunting of normal emotions, which really isn't the goal after all, is it? Now, let's take the non-stimulant, atomoxetine, for instance, the norepinephrine reuptake inhibitor. That's Strattera. What does that do? It has no effect on the limbic system whatsoever, but it activates the anterior cingulate and the frontal lobe. It activates the executive that is managing the emotion. So what would I predict from that? That atomoxetine will be better at regulating the emotional symptoms of ADHD than the stimulants will be. Because it's doing it at the site where the problem is, at the site of the executive system that isn't down-regulating affect to the extent that it should. You will also find that atomoxetine does not produce the side effect of emotional blunting. There's never been any complaints about that in any of the literature to my knowledge. Now you know why we are seeing clinicians in this country combining these medications. And they're doing it to get greater coverage across this range of ADHD symptoms. The stimulants are really good at improving your attention and executive system, your cold cognition, your working memory. They're not so good at necessarily handling the emotional dysregulation. So by adding in a non-stimulant, you're able to keep both drugs at lower doses, that's always a good thing, and get wider coverage across the ADHD symptom complex, including emotional dysregulation. Now, what about the third drug that's on the market that came on the market a couple years ago? Intuniv. Intuniv is guanfacine XR, extended release. Guanfacine has been around for years as an antihypertensive drug. It's used to treat high blood pressure, but it also has been known to have psychiatric, psychopharmacological properties. And it is beneficial to people with ADHD and Tourette's syndrome. So Shire simply took and reformulated it so that the drug lasts longer. Now, what does guanfacine do? Well, guanfacine is an alpha-2 regulator. It goes to the frontal lobe and it fine-tunes the signal in nerve cells. So unlike stimulants, which affect the expression of dopamine and norepinephrine, but mainly dopamine, and they do it usually through increasing production and blocking reuptake, guanfacine has its effect by latching onto a nerve fiber and opening or closing the little ports along the nerve cell, the alpha-2 ports. And if you close the alpha-2 port, the signal is stronger down the nerve cell. If you open the little alpha-2 port, the signal gets dampened and noise comes into the signal. What guanfacine does is to fine-tune frontal nerve cells so that signals are stronger, less confounded by noise, more likely to reach their endpoint and have an effect. So this would argue that, like atomoxetine, guanfacine might well be activating the executive system so that the signals from the executive system are cleaner, purer, stronger. Here again, you might use guanfacine like you use atomoxetine to address the emotional component of ADHD where stimulants might not be so good at doing that. And what are we seeing in the US today? Clinicians combining Intuniv with a stimulant to do just that. Lower doses, much more pervasive coverage of ADHD symptoms. So by understanding how the drugs work in the brain, we have a better understanding of how they manage the emotional aspect of ADHD. By the way, 70% of the brain areas activated by the ADHD drugs are shared. So they have a lot in common, which is why they're ADHD drugs. But 30% of the effect of a drug is not shared with the other drugs. And it tends to be mainly in these emotion regulation centers that we see some of this non-overlap of drug response. But let's also understand that if ADHD has gone on long enough with oppositional disorder and emotional dysregulation, there are going to be downstream impairments that are going to develop, like demoralization, peer rejection, school failure. And you can treat this child, and you can't get rid of that history. That's there. And that has an impact going forward on that individual, some of which is irreparable. You can't regain friends, dates, marriages that you've lost just by the fact that we can now better regulate your ADHD symptoms. Again, another argument for earlier rather than later intervention is the prevention of downstream secondary harms that accrue to the person as a result of unregulated ADHD. And then, as we mentioned, the social ecology is very important, particularly parenting, and we may need to get in with behavioral parent training classes to help these parents. But if you're going to do that, you have to keep in mind that you have to screen all parents for ADHD before you do behavioral parent training, because they'll fail if you don't. You must manage the parents' ADHD symptoms to make them responsive to the training. And if you don't do that, they will fail. The single best predictor of families going through behavioral parent training as to who will fail is that the parent has ADHD that you're trying to train and you haven't done anything about it. So don't bother taking an ADHD adult through a parent training program if you're not managing their ADHD. You're wasting your time and their money. Which is why you hear us arguing, as I have for a decade now, you always screen every parent that brings an ADHD youth to your clinic. Because you need to know whether the genetics are such that that parent shares that same disorder, and that that parent's disorder is going to interfere with your plan to help this child or adolescent or young adult college student with their ADHD. Now, there are ways that you can help the ADHD individual better cope with their emotions. And one way to do that is to use Gross's model of an emotion and see where we can intervene. So let me wrap this up just by going very quickly through what is one of the most well-established models of human emotion in the psychology literature. And it is this model. Right? When you have an emotion, you put yourself in a situation, something happens in that situation, and that provokes your attention. You attend to that stimulus. That then generates an appraisal of the event. Is it good or bad? Do I like it or not? This is where the emotion comes from, and then you respond. This happens, by the way, in milliseconds. This is the automatic brain. This is what it does, and it does it very quickly. But it still helps to break the stages up. Because if you want to help somebody manage their emotions, those are the 5 places you will intervene. And let's talk very quickly about what you could do. First of all, let's see if we can predict where you are likely to keep having these emotional outbursts. Can we avoid those situations? If you keep stopping at the same bar after college in which you keep getting in fights with the people at the bar, don't go to that bar anymore. Go somewhere else, but not there. Right? So just situation selection can be a coping tool for people with emotional difficulties. If you find yourself in a situation that is emotionally provocative, is there something you can do the next time in that situation to avoid that? If you're sitting in a classroom, if you're at a conference table, and there's somebody in that room that you know you don't get along with, don't sit facing them. So that you don't see the smirks and the sneers and the little asides that this person is doing to provoke you. Sit so that you can't see them. Modify the situation. Now, what if it's gotten out of hand? Right? This is where you do attention redeployment. Cover your eyes, look away, stand up, leave, get the hell out of there. But terminate the interaction with the provocative event. Then you get to this one, cognitive behavioral therapy. Learning to talk to yourself, to reason through the emotion, to reappraise and reevaluate its importance to you. This is traditional CBT as it's practiced in the US anyway. Or you could be learning mindfulness meditation. Either one. But what are they doing? They're helping you to reappraise the emotion. It's not that important. Count to 10, go to your happy place, deep breathe, there you go. And then finally, all else fails, suppress it. Squint your face, sit on your hands, but if you have to, terminate the motor response. Now, here's what we've learned in years of research on this. The earlier in the sequence you intervene, the more effective you are. The later you intervene, the less effective you are. So one of the things we've learned in helping people cope with emotional dysregulation is that CBT, which is very common in clinical practice, is very late in this sequence. And you could improve your CBT counseling by moving further ahead in the sequence and giving them coping and compensatory strategies for dealing with those situations. And I've given you a few descriptions here that we don't have time to go into. But the point is this: by breaking emotions down into the 5 stages, we better learn how to help our clients in dealing with that dysregulation, apart, of course, from giving them medication. So what have we learned? We've learned that emotion is just as much a part of ADHD as inattention, hyperactivity, and impulsivity. We've learned it's part of the neuroanatomy, it's part of neuropsychological theories, the evidence base shows it's there, it predicts impairments we couldn't predict without putting it in there otherwise, and it helps us with our clinical differential diagnosis of ADHD from other disorders, and it helps us understand our management of the disorder. So what else do you want, people? If you were a jury, would you vote to put emotion back into this disorder? Yes! Okay. Thank you. You're welcome. Okay, we're a few minutes past our time. What's new? Right? I'll take any questions that you might have. Anything today? I'm never coming back here again, so. ODD, right. Right. Yes. It wouldn't lead so much toward ADHD. She's asking about children who come out of orphanages, who may have been malnourished, abandoned, neglected. What is that contributing to? Well, we know that the background of that child is contributing to their ADHD. Malnutrition is part of that, not the neglect, but the kids who wind up in Romanian orphanages are kids of alcoholic parents in a war-torn country that often have been malnourished and their parents have smoked and drank. Everything I just listed is a known cause of ADHD. So that aspect of that orphan would in fact be explained. The ADHD part of that would be understandable. Right? Now, what about the orphanage itself, the neglect, the abandonment? What might that do? Well, what you would tend to see is more of a blunting of the individual's ability to interact with others. Very inappropriate behavior, if not aloofness, blandness. I mean, there's a point where the individual almost becomes like a feral individual in terms of their ability to interact with other people. And so, yeah, you might get like a feral reaction, reactive aggression and anger and so on. Right? But part of that is simply failure to be exposed to any learning environment. You can't learn normal self-control if there's no environment teaching it. Right? Whereas in the ADHD typical case, it's not so much that the individual hasn't learned it, the individual has been trained by the parent in how to use their emotion as a social tool, as a device, through that 4-factor model that we explained. Okay, sure, yes. Yes, can ADHD contribute to substance abuse and addiction? And not just substances. There's now a growing literature, particularly out of Asia, on the risk for internet addiction in ADHD individuals. 16% of ADHD youth have a severe internet gaming addiction. And it is predicted, first of all, by the risk-taking, impulsive dimension of ADHD. Second, by social rejection, okay, which we've talked about. That's the emotional thing operating there. Third, the development of social anxiety as a result of the peer rejection. Those are 3 factors that are known to predict that, and then later, depression. What happens is the individual creates a false social group on the internet as a substitute for real-world social groups. You can create your own persona on the internet. It's fake. It's false. You have a whole new identity. You can be whatever you want to be. You can put up your own picture. It doesn't have to be you. So what we find is that these people start to develop alternate social networks, sort of pseudo-buddies, virtual friends. But these are not real friendships. And what we find is that they start to become addicted to gaming. But there is a risk. 1 in 4 ADHD youth will develop a substance use problem.
Excuse me, sorry, I have to cut it off.
Oh, I'm sorry.
For another speaker.
Oh, my goodness. We were done for the day. Okay, well, I'm going to have to let you go. But the quick answer is, yes, it does contribute to drug abuse all the way down the line, which means if you work in a drug abuse clinic, 40% of the people you're seeing are adults with ADHD. Okay? If you have any other questions, send me an email. Thanks so much for coming out today. Enjoy the rest of your day. Thank you.